Welcome to the Urology Coding and Reimbursement Podcast, where we help urologists and staff achieve peak economic and practice efficiency so there is time and energy to focus on patient care and a happy life. I'm your host, Scott Painter, with my co-hosts, Mark Painter and Dr. Ray Painter. Welcome to episode 52 of the Urology Coding and Reimbursement Podcast. I'm your host, Scott Painter, with my co-hosts, Mark Painter and Dr. Ray Painter. And today we have a special guest, Dr. John Lynn. Welcome, John. It's great to have you on. We are going to be discussing today letters to physicians regarding their E&M billing levels relative to their peers. So John brought this up as a good topic to discuss. Do you want to share a little bit why we chose this topic and what we want to accomplish here today?
You bet. Thank you so much for having me on. First of all, let me just thank PRS Network for helping me reach the level of success that only a very few can imagine. So I'm very, very grateful to be able to pay it back and pay it forward. As the administrator or the guy who started this Facebook group called the Thriving Urology Practice Facebook group, I have the privilege of being able to see the amount of engagement from various posts by people. One of those posts recently came from a physician who said that he posted a picture of this letter that he got from an insurance company saying that, hey, guess what? You are billing above your peers when it comes to certain E&M levels. And that's what prompted me to bring this topic to you and say, hey, let's talk about this.
Excellent. So, Mark, I know with all these letters that they get, you had some. You called it a what'd you call it? A badge of honor or something like that.
Yep. An award, a mailed award from the insurance company. We see these all the time, and you know they're definitely not new, and they're not uncommon. As the insurance companies go through and try and regulate a little bit how physicians bill. It's, peer pressure. They do a few different things. Pull your charts ahead of time if they, put you on chart polls. And those letters are just, to me, badges of honor. That means you're doing well, because when we look at, and I can tell you that we have been doing a number of audits for a bunch of folks as they're trying to settle into 2021 guidelines. And when we jump in and we're doing the chart reviews, I'm seeing the trends there that support, and I'm also seeing that physicians haven't yet embraced what the reality is, meaning they're undercoding because they just don't feel like, wow, does this really qualify for a 4? So it's getting into that internalization piece to actually get the comfort that you really are at a level 4 for an established patient or a new patient with 2 problems and a drug, or with gross hematuria. I mean, there's just so many of those that hit solidly on those 4s. And people are like, wow, this is a lot of patients at 4, so they're dropping some. So that's what we're seeing on the audits as well.
And John, have you received a recent letter like this, or?
I think I get one of those letters at least annually, and like Mark said, I call those badges of honor or a trophy. I think physicians are. It boggles my mind that when I hear other urologists, other physicians say, "Oh, I just want to be average. I want to make sure that I am just like what Medicare's distribution is for the various E&M levels." And that highly, in the past, pre-2021, in the past, that's always the largest peak. It's like a bell distribution with a slight shift to the right. The biggest peak is around 99213 or 203, towards the middle. It's a normal distribution. And it boggles my mind why physicians, when we are not the average, when it comes to medical school and getting into medical school, why we strive to be average, to be 99203 or 213. When you have the medical necessity, when you are justly bill, you can justly bill for the right level, which is a higher level. Why we want to be average, that boggles my mind. And I think Mark had alluded to it already, which is a lot, especially in 2021 when the E&M rules changed for outpatient and other office visits, office or other outpatient visits. The rules have changed in 2021. It is less cumbersome when it comes to documentation. When you have the medical necessity, when you have your situation, your problem, your data, and your risk to back up your level 4 visits, and like Mark said, it is a lot easier now to reach a level 4 when you have medical necessity and the documentation requirements are lower. It behooves you to really understand the rules and use it to your just advantage.
Yeah, and I'll pile on a little bit more on a couple of different things. So, first of all, everybody was scrambling to be average, thinking that they can avoid audits or being flagged or being an outlier, those types of things. That the reality of life in our healthcare industry right now is there is no way to code not to get your charts reviewed. That is I won't call it the beauty, but from the insurance company side, one of the tools that they have at the ready and they use very frequently is a request for medical records. They're doing those routinely on just about everybody, regardless of how you bill. So they're going to look at your records. That's just the fact. So embrace it, understand it. And I will say that I have had recently more people from the insurance side and more takebacks related to poor support for data, which is why we focused a lot of our podcasts recently on supporting your data and using your data appropriately in your medical decision making, and the ordering of tests. I mean, the unnecessary tests that are out there is a big target across the board. So that is really where that focus is. Now, the other thing I will say is that Medicare and all of the other payers are using older data, right? I mean, they only have 1 quarter's worth of data on the new E&M codes. So that curve is completely blown out of the water. So you're comparing apples to oranges moving forward, and they know it. But they just run their same patterns of, the straight bully tactics of, hey, you're coding a little high, and enough physicians crawl back down that the letters work. It's what I call I would say it's encouraging self-denial, which saves the insurance money. If you never try to bill a 4, you're not going to get paid. It's kind of like golf, never up, never in.
Well, it almost seems like that's kind of a litmus test, if you will. The minute you get that letter, when you open it up and you read it, if you're uncomfortable, that means you probably have to learn a little bit more, probably a lot more about E&M coding. So if you open that thing up and if you blood pressure goes up and all of a sudden you feel very wary when you open those letters and see those distributions that you're not following in, if you're not comfortable with that and view it as that award or that badge of honor, then you probably need to get some training. Is that right? Is that what that's kind of a very simple test.
This is John. I completely agree. And I remain to this day a student of coding and billing. And I tell the residents who are out of training, number 1, to live below your means, and number 2, to learn about coding and billing. Because if you participate in the insurance game, you have to understand the rules of the game. What we're doing, what we're telling the audience is nothing but really applying the rules that are already out there. It's no different than applying the deductions that you would take on your IRS return. Those are the rules. Follow the rules and you're going to be okay. Don't worry about the audits. Audits are going to happen. Every time the insurance companies are asking for your records, what do you think they're doing? They're making sure that you are billing correctly. And if there's a big problem, then they'll let you know about it. So don't worry about billing 99204, 214. If you have medical necessity, if you know the rules of the game and you can back up your billing, by all means, bill for the 214, But the problem is physicians do not have a lot of physicians do not have a clear understanding of the E&M rules. And I know I've learned a lot from PRS Network, you guys, regarding the E&M rules, and Mark is always bringing the latest and the greatest and on how it helps physicians reach their maximum potential. And in the meantime, you are learning the rules so you don't have to document excessively, so you have more time to take care of patients and live a happier life.
Amen.
Yeah. So, John, I'll also tell you, I recently got an email from one of your thriving urology practice members that was saying that within their practice, they have a lot of folks that have been watching the thriving urology practice, and they've started to see an uptick in their fours. So that the fact that everybody is sharing that information, and there is comfort in numbers, if you will. That's kind of the way we are, a little bit pack animalish. And ultimately, the other piece that has been always a bully pulpit of mine to a certain degree is if we can get everybody trained to do things the right way, then the curve will take care of itself. That's really the bottom line. And if everybody would do what they're supposed to do, which is put their mental thought processes down on paper, the way that they're thinking about all of this. Urology is a specialty, right? Rheumatology and if you take a look at other specialties that deal with multiple diseases and chronic states, and even some of the episodic stuff you're taking patients to surgery. They have multiple problems. They should be higher level codes. And those specialties, their numbers are at 70 to 80%, even under last year's numbers. So, urology still just needs to, and that's the other way to look at this. You're catching up with the other specialties to actually getting paid for what you do. So
I say
it was fun.
Yeah, I say it's time to drop the cloak of victimhood. It's time to take charge, learn about E&M coding, and bill what is justified, and don't be afraid of audits, because they're going to happen. Whether you're billing a 203 or 213 or 204 or 214, level 3 and level 4, you're going to be audited no matter what. So just bill correctly, learn the rules, and live happier so that you can practice more happily and take care of more patients. And make sure you give your staff the necessary bonuses to keep everybody happy, because right now it's very difficult to find those good workers.
That's so true. And
it's difficult to find workers at all.
Yeah.
Which is tough.
And coding is hard, and you got to learn it, and you got to spend the time. And finding a good coder, a good biller is, you want to hold on to those and compensate them well. We've seen that in our, with the coders that we work with and hire. We have to train we have to train all our coders to get up to a certain level so that we can, so that they're productive and they can contribute to what we're doing. And it takes, 6 months, a year to get them really up to speed. So you got to keep that staff that's good and quality.
Although HR is almost always a big chunk of the practice's expense, it is a lot more expensive to find somebody to train that new person, because you're down literally 1.5 employees. You have someone who's training that person, and then you have that new employee. So it is. I always give this suggestion. Pay someone so well that they wouldn't want to leave. But if they want to leave or they're looking for a job elsewhere, I will help them find another job. But anyway, when it comes to coding and billing, over the years, it's repetition. It's learning about, in my case, it's learning about the 95, 97 rules and being a student, being willing to learn. And then when 2021 came along, the last few months, the new rules came along. I based my knowledge from what I knew in the past. So learning about the new rules, it wasn't a big transition. You kind of have to learn the basics first and then build on top of that. I think over the years, with all the courses and the seminars that I've attended through you guys, PRS Network, it's built my foundation, my understanding. So now that I have a little bit of an understanding, I can teach it to the folks on the Thriving Urology Practice Facebook group.
Excellent. Yep. And obviously they're out there listening to you because I'm getting all these questions coming from your way. So the other thing I'll add on all of this is, one of the pieces that I think a lot of people don't do is have somebody take a look at your records and make sure you're doing things right. Sample some charts and take a look at how you're documenting, so that you have somebody else's perspective. That'll also give you some confidence as to what you're doing. I can't tell you how many of the offices that when we run through and we show them where they fit as far as their documentation, when we do those educational chart reviews, and we say, you know what, we looked at 20 charts for you, and 50% of them were undercoded. That's an eye-opening experience across the board. And we're seeing that quite a bit with groups that we're doing some chart reviews with. So it's something that can help. So have somebody take a look at your charts, do some extra work right now, and as John said, lay that foundation, and meet with your peers. If you're in a group practice, sit down with your group and go over chart reviews so that you can all feed off each other to figure out how to use your EHR, leverage it as a tool that it should be, and get better coding. And I know, John, you've really leveraged your EHR.
Yes. So speaking of documentation, like you always, PRS Network has always harped, you got to document it. You got to write down your thought processes. And one of the ways to help make that easier for physicians is to use some sort of a scribe, whether in person, or some urologists have started using virtual scribes to help you document your thought process. The other thing, which is what I use, is voice recognition. Use Dragon or M-Modal so that you can think out loud using voice, so you can document a lot easier in assessment and plan why I'm ordering that urinalysis. Why is the PVR important in my medical decision making? So I want to make sure that I tell my practices that, hey, you want to make it easy for physicians to do their jobs. And humans inherently we want to do two things. Number one, we want to thrive and survive. And number two, we want to do that in the easiest way possible. So anything you can do to help your clinicians decrease that friction to what you want, the results that you want. Any time you can take away that friction in terms of using a scribe virtually or in real life, or maybe voice recognition, it's a lot easier than typing. I can type about 75 words a minute on average, but I can speak about 160 words a minute, and it automatically transcribes that in my EHR. So leveraging the technology that exists today, make your life a lot easier, document so that you can explain to a high schooler why you're billing a certain level. That is important. And also, lastly, understanding the rules of the game, understanding how E&M works, and really it's just repeated exposure. The other thing that I tell some of the members, now PRS Network on your website, you guys have a nice community where members can ask billing and coding questions. And this came from a physician who said, well, I feel like gross material workup is a 99205. It's a problem, a new problem. And I'm doing this imaging, and I'm scheduling for cystoscopy. I'm looking at outside records. I think that's a 99205. Something I've always said before, and I say it over and over, Medicare's rules do not care about your feelings. Rules do not care about your feelings. Rules are what they are. Learn the rules, apply them to your advantage, but then make sure you understand them so that you don't overstep your bounds.
So true.
That is very true. It's the old rule of your logic doesn't apply.
So John, got a question for you about how you look at your, how you do your auditing internally, or how you look at your E&M practices to make sure everything is on track. Do you do any reports, or do you pull any of your own charts and have somebody else audit it, or how do you do it?
Well, I attend a lot of your courses. I do a lot of self-auditing, and external payers are constantly asking for records. I look at every outside record request and I look at the patient chart, is this coming from a law office? Is this a disability determination? Is this an insurance request? Is this a patient who is switching urologists, insurance coverage changed, etc.? So I look at every chart review, and that's my form of third-party external audit. If I'm doing something really egregious, it will be pointed out to me, for sure. And also understanding the rules by learning them. And there's no better way to learn the rules than to teach it to somebody else. So when I get on the Thriving Urology Practice Facebook group, I will try to teach certain concepts. And if I'm really out of range, out of bounds, these certified coders and billers will take me to task. No better way to have that external audit than to show what you know and have somebody say, you're right.
Very good. Mark, you had mentioned some trends that you can't really come up with specific numbers of E&M trending values for the first, with the new rules, but you have pulled some information out. Can you share kind of what's going on with what you've seen and where we are and what you're seeing, but understanding that it's not complete data?
So, so basically what I'm seeing is in our benchmark curves for urologists. And by the way, I mean, when you look at benchmarks and the way things go, again, Medicare's going to be, they're way behind. So they're not going to update their benchmark curves for a while. They have to, they're just slow in their big data analysis. But what we're seeing so far is an increase in level 4s in the new patient side. For the first time, we've seen it crest 60%. I think in the end, we're going to see that the level 4 hit closer to 70% of new patient visits in urology, or even maybe slightly higher if everybody truly gets on board. And then there's the established patient, which actually is bumping even closer. I've always said that, originally under the old rules, that we should have been about even with 3s and 4s going forward. And people were about there at 42, 43% in the 3s and 4 range of those folks that were doing it well. Although the old numbers had it at about 35% level 4s. The new numbers that they got just recently are already up to 48%. And so I am now, as we get through this, and I haven't yet gotten the full gestalt, but I will say that as I've looked through all these charts, I don't think, because the coding is now based on medical decision making, your follow-ups are going to be closer to your news in the coding pattern long term, because we've got two stable chronic illnesses and drug management moving forward for a lot of your patients, or you're taking people to surgery with data that you're reviewing the way that's looking forward. So I think we'll settle in, and I'll get that kind of figured out. We've got a few more months worth of data coming through before I get to the what do I think it should be stage. But I'm leaning more towards that established patients going to be, that level 4 is going to be closer to 60%, if not higher, under the new guidelines. So we'll have to watch all of this. And of course, we know that Medicare will eventually start figuring this out because it's budget neutral, right? In Medicare. So if you don't understand the rules on the E&M, it's going to hurt your overall income with Medicare because that pie is fixed. So you've got to make sure you're playing the game and doing it right. Otherwise, you're going to get hurt overall. So it's still, that motivation's still there. And hopefully everybody's going to watch the Thriving Urology Practice and come to our seminars and really lay that foundation moving forward, because this shift really was about shifting things more to cognitive and to that patient interaction in the visit and getting the patient to the right end goal as fast as you can. I mean, that's the That's the push, the triple aim that they're talking about with public health and patient well-being, and all those things in the triple aim are all about getting to the right conclusion, treating them, and getting out and getting them better.
So I'm looking at my, this is John again. I'm looking at my numbers for this month, and I will tell you that my level 4s are about 70% of all of my E&Ms. All of my established patient E&Ms. And it's important you don't look at these numbers in vacuum, because I happen to do a lot of vasectomies. My vasectomy patients are unfortunately now a 99203 when they come in for an evaluation. In the past, you could justify a 99204 if you put in the work. But I see a lot of vasectomy new patients, so I'm skewed in my new patient E&M codes in that I see a lot more 203s than 204s. And I'm just taking a snapshot of current month's information. I'm seeing that 203 is higher than the 204s in my practice. So you can't look at these numbers in a vacuum. You kind of have to look at what kind of patients you're seeing, what's your demographic, and then go from there. So it's important to not be misled by what other people are doing. My recommendation is understand the rules and do you. See your patients, go code correctly based on how your patients are presenting to you. And don't try to keep up with the Joneses, and just do you and make sure you're doing it correctly.
I'd like to back up what John says. This is Ray. John has said several times you need to understand the rules. You can't memorize the rules and apply them. You need to understand the concepts and how to apply the rules. And John has done a good job of that. One other little point I'll make. When Mark and I first started giving seminars after the rule changed in 1992, I used to tell docs that I was out there trying to get them to understand and code better so they would not make me look so bad, because my skewed numbers were really high back in those days.
Yeah, coming back to that, the letter that you get where you are shown, hey, you are X% higher than your peers when billing for a certain code, as if that's something bad. But I think clinicians should be proud that they are billing correctly. And if they are in doubt, like Mark said, if they're in doubt, make sure that they are doing some sort of auditing, make sure they understand the rules. And I welcome the visits. I welcome the audits.
All right. Well, let's
good philosophy.
Let's wrap this up and let's get some final thoughts. Ray, any final thoughts?
No, I think the only final thought is I would encourage everybody to really take a close look. The two things we didn't have time to talk about are level 5s and time, but we should cover that in another one, because as we see more level 4s, we're probably seeing a few less level 5s. Is that correct, Mark?
Yes, we are. That 5 is harder to get to.
Yeah, level 5s are much, much more difficult under the current 2021 E&M rules. Most commonly is probably going to be something that's an extended visit, an E&M visit based on time.
All right. Final thoughts from you, Mark.
So again, foundational learning is key. As you start to really leverage the ability of these guidelines to streamline your practice and the documentation that's there, your ability to template and use everything and follow the way that the E&M calculators are out there is not going to keep up with some of those changes. So making sure you understand the rules and you're picking your codes that you know, most of you would know going into an office visit with a patient what the level should be. If you can get to that level, you're going to make your life a lot better across the board.
Final thoughts from you, John.
Your patient success depends on your success. And I hope in this short podcast, we have been able to help you today reach your level of success. Try not to be average, code correctly, learn the rules.
Love it. All right. So my final thoughts. Well, I'm just going to do some housekeeping. Number one, you can contact and get in touch with John. I'll put the Thriving Urology Practice Facebook group link in the show notes. But if you want to join, you can go request to join that group. We encourage you to do so and participate. Also, you can go to prsnetwork.com/052 for this episode, and you can join the Urology Coding and Reimbursement group where you can ask any questions. And also in the show notes, we'll put a link to our recent E&M workshop recordings so that you can really learn the rules. If you want to sign up for those workshops, we do have those. Those are on-demand learning. So those are still available, and we do encourage you to learn the rules. So with that, I see, John, you have a final thought?
Yes, if I can just give your seminar a plug, the Urology Advanced Coding and Reimbursement Seminar, it is back live. And in December of this year, you guys will be holding this seminar in Las Vegas. I love it. It's always a good time. And the entertainment is always there, either on stage or off stage. And also, this same seminar will be held in New Orleans in January of 2022 in person. So I'm looking forward to those meetings.
Yes, thank you very much, John. And we are so looking forward to getting back in touch with everybody, seeing everybody face to face. All right, with that, we'll wrap it up, and I will ask final words to you, John.
I will steal the words from Dr. Ray Painter. Happy coding.
Thank you for listening to the Urology Coding and Reimbursement Podcast, where we help urologists and staff achieve peak economic and practice efficiency so there's time and energy to focus on patient care and a happy life. Special thanks to Carl Painter for the music today. You can find his music under his record label, The Juicery, with extra pulp and special guests.